Come in based on medical decision making. Go on. This is where your data points, problem points and data points come in to drive it. This will make a little more sense when I get to a couple of the vignettes. So let's go on because we're going to run out of time. Now, typical time is a guide for the codes. They run anywhere from no face-to-face in your lowest level code, 99211, which you can use if somebody stops by to pick up a prescription. You can charge for that. 99212 is like 5 to 10 minutes, a very simple problem for primary care. Somebody comes in with a splinter and needs it removed. No medication, anything after that. Most of our codes are going to be 99213, which a typical time is 15 minutes. 99214, typical is 25. And 99215, typical is 40. And then you can look at, is the time rule best for you versus doing the combined coding we'll get into with the psychotherapy. Go on. Okay, now remember, this time, the typical times really are for efficiency's sakes. If you can meet the requirements of a code in less than the typical, so be it, as long as you've met the requirements. You don't have to document time. It's the elements you need to be documented. But your appointment book should more or less correlate what you're doing. You're not going to do, 25 99215s in a day. They would probably pick you up on that. Okay? And as we said before, counseling coordination of care, if it's greater than 50% of the total time you spent with that patient, you can go to the code of the typical time where you're meeting that. Okay? It's gone. This is the times the controlling factor. And it's the face-to-face. In other words, if you're coding a high-level visit for 40 minutes, you better have spent 40 minutes face-to-face with the patient. Don't say, well, I spent 20 minutes or 21 minutes, so that's half of it. Because you're still within the code before you was a 25-minute typical, so you're within that. So really, you have to spend 35. Probably best just to spend 40 if you're going on the time rule. Okay.
Is that going to be existing in 2015?
Yeah, this is E&M. This is the E&M time rule. This is different from what the psychotherapy combination. Okay, let's flip through. Okay, counseling. Okay, what does counseling consist of? It's the talking to the patient about your diagnostic impressions and a lot of diagnostic results and everything else. Okay, you can just go ahead and click it. Okay, so this is counseling. Oops. Okay, so this is counseling. For years, your teachers kept telling you to settle down and sit still. You can stop now. Okay? To me, the counseling is you should, you must, do this, do that. That's not how we do psychotherapy. We don't give orders or straight recommendations. We do it in other ways. Okay? So, now, just to review, we're coding by medical, the complexity of medical decision making. And this is all based on stuff we've talked about in terms of the medical problems, the chronic illnesses, and the exceptions is if we go for the time. We're on a checkup, actually. Somebody you haven't seen for a year, year and a half, college kid comes in and says, gee, I want to touch base. I think I need to go back on my medicine. In that case, you can code a high level based on history and physical. Even though the level of complexity might be low and the risk might be low, the fact that you've had a gap of treatment less than 3 years, but significant in terms of the overall course of the patient, that's the one exception in this. If you haven't seen a patient over 3 years, then you're into a new patient again. Okay. Flip on. Go on. Just keep going. We covered that. Okay. And now this is just going over what a new and established patient is. A new patient is one that you have not seen before or within the past 3 years. An established patient is you have seen them. Okay. Click. Seen means it's you've seen them, or if you're in a group, a person of the same specialty in your group has seen them, or if you're covering from somebody, it's an established patient of the covering physician, in which case it becomes an established patient for you. So that's just the definitions of that stuff. Go on. Okay, this is just that chart, so go on. This is more of the chart. Now, let's go over a couple vignettes. I'm not going to go over all of these because we're not going to get to the other component, the psychotherapy part. So I just want to give you an idea of how to code an E&M visit. So we're going to take the 16-year-old female, established patient, diagnosed with anorexia 6 months ago. She's at 87% of her ideal body weight at the moment, and she describes increased feelings of panic when she has meals. Next. Okay, so let's go through the guide sheet. Okay, what are our problem points? Okay, the things you want to talk about if the panic is worsening. It is 2 points. If it's a new problem, it's 3 points. Okay? If it's new and you're ordering a workup because maybe you think, oh, gee, well, maybe she has mitral valve prolapse the way she's describing these palpitations, that would be 4 points. Okay, data points here. Okay, saying we're reviewing some lab tests and we ordered something just to make sure that, you know, nothing else is going on. That's a point. If we obtain the history from someone in addition to the patient, such as the mother who brought her to the patient, you get 2 points for that. Okay? And if we give a rating scale and we score it, we get another 2 points. Okay? So, now what's our table of risk? In this case, it's moderate because it's a chronic problem with a mild exacerbation. And there are 2 or more chronic conditions that we're dealing with, malnourishment and anorexia. Okay, if she has a severe exacerbation, she's not eating, and she's starting to lose weight again, and the illness is starting to threaten her life, you're thinking she needs to be hospitalized, that puts you in the high-risk category. Okay? So, we need 2 out of 3 sections to get your medical decision making. So for problem points on this one, you know, if we're just saying it's an established problem that's worsening, that's low. We had no data points, and so our risk was moderate. So your medical decision making in this case is low. Okay? If we go, okay, it's a new problem, but we're not working up, we got a moderate level of we got 3 problem points, which is a moderate level. We don't have any workup, so we're not getting any data points, and that puts us at moderate. And if we're going to work this up, we're getting 4 problem points. If the patient's in danger of needing hospitalization or even going to a more intensive outpatient therapy program for eating disorder, that's putting you into high risk. And if you have a lot of tests and stuff, the rating scales and stuff, you're getting at least 4 data points. It's high. Okay? So let's break down this history and see where we're going to go. Okay, just stop there for a minute. Okay, so there's our history. It's detailed, and we need 4 elements or 3 chronic conditions. So if we have the panic attacks, which is the location. We have before meals, which is our context, lasting 5 to 10 minutes, which is timing, for going on for 2 weeks, which would also be part of timing and duration. It's worsening, so that's your severity. What makes it stop? Leaving the table, modifying factors, and anything else happen during this time? Chest pain, lightheadedness, associated signs and symptoms. So there, you've already met the criteria for a moderate level history. Now, past family social, you need 1 element. Okay, she's in 11th grade. You got it. Okay? Review of systems, we need 2 to 9 elements. So, neuro, she has headaches. GI, she gets stomach aches. She has chest pain. In the psych evaluation, she's getting anxiety and panic. And we find out in GYN, she's having irregular menses. So we got plenty of ROS there. That's all we need. And we just say all other systems are examined and negative. Which you probably don't even need for that, because this is not the highest level. So our medical decision making here is pretty much moderate complexity. Now, if we were doing the examination, I mean, you only have to do one or the other, either history or exam. So our chief complaint, again, is panic at meal times, and this would be our physical exam. And we need 9 bullet points for moderate. So you can flip through those. So this would be the things we could do. We could do speech, language, association, abnormal thoughts, judgment, insight, orientation times 3, mood, affect, thought processes. And then if we want to go in the constitutional, we could do her vital signs, height, weight, and respirations. Or you could describe her general appearance. Either one would satisfy constitutional at the moderate level. Okay? So our medical decision making on this one, moderate. Okay? Now, if we wanted to expand this, we felt to a 99215, what other things would you have to be doing that are medically necessary in this for the comprehensive history? So let's see what the history can be expanded. So we still need the 4 elements or the 3 chronic conditions. So we have the panic attacks. We have all of that. Click. Now we need 2 elements for our past family social. So we can still say the patients in school, and then what we find out is that the mother has a history of high anxiety as well. So that's a second element in family history. So we have a social and family there. We do basically the same ROS, and then this time you put in the caveat, all other systems examined and are negative. Okay? And that gets your medical decision making at high. When you do the comprehensive evaluation. Okay? So, now for physical, that was your history. For the physical, for comprehensive, we have to have all the bullets in constitutional and psychiatric boxes and the 1 bullet in musculoskeletal. So, for constitutional, we got our vital signs and our appearance. The rest of this is going to be our mental status. Which you have to do all elements of the mental status. And then we'll get down to musculoskeletal, and keep flipping. There we go. Musculoskeletal, you're doing either muscle strength and tone, which is diminished, and gait and station. You really only need 1 of those 2. You don't need both. And that puts you in the high medical decision making. Okay? Now, we'll do 1 more. This is more of a child, simpler visit. So this is a 10-year-old ADD oppositional behavior taking stimulants, scheduled for his follow-up visit. So what are our problem points? Established problems, we have 2. ADD oppositional behaviors, 2 points. Okay, data points. We obtained the history from someone other than the parent, or the patient. The mother came in, so we get 2 points. Okay, risk. Prescription drug management, that's moderate risk on our risk table. So our medical decision making, we have to make 2 of the 3 must be met or exceeded. So what do we have? Click. On problem points we have 2, data points we have 2, risk we have moderate. Okay, 2 are in the low, 1 is moderate, so 2 out of the 3 is low, it's low. Complexity, so our code will come out to 99213. I know, I'm erasing this. Okay. Okay. For the problem points, we had 2, ADD and oppositional behaviors. Okay? So I got a 2 problem points. Okay, all right, data points, we had to take the history from the mom. In addition to the kid. You know, we talk to the kid tells us everything's, oh, I'm great, you know. I'm student of the week. Talk to mom, the kid was suspended last week for, you know, throwing a chair at the teacher or something. It's probably a higher risk, but okay. He's on stimulants. As soon as you prescribe you the medication, and you know, again, you know, stimulants have all the black box and all the other nonsense warnings, but it puts you at moderate risk. However, because only 2 of the sections, problem points and data points, are in the low level category, you only qualify for a low-level code because you have to get 2 out of the 3.
So if I spoke to the guidance counselor the day after the appointment and put that and documented it, that would make it a data point 3, and so
exactly, and then you could go to a moderate. Okay? So again, if you do, but it has to be medically appropriate. And you know, if this kid is acting out in school, it's medically appropriate. If the kid's doing great and everything's wonderful, and the kid says he's doing great, and the mom substantiates, yeah, he's doing great, you know, he's getting better, you wouldn't be calling school probably, because there's no need to. Okay. 1 more question, then we're gonna have to go on. Yeah. Who's ever?
We're
talking about the 9-9 codes for the medical decision making and the level
Yeah.
of severity in this, right, complexity. Would you also, would that be in addition to the 9-0 whatever code for?
We'll get to that. Next section. So if we can get through this, we can get on to this next section. Yeah, we got to move on. We're never going to get there. So let's hold on. If your questions aren't answered, I'll stay afterwards to answer them. So just write them down. Okay, now, if you wanted to do the, on this one, the way we got it, we did an expanded focused history because we had the two chronic conditions or the two problems. And so there's your problems, okay? And we didn't need a past family. We only needed one system on the ROS. So we had psychiatric, no depression or anxiety. And then for our exam, we had the 6 bullet points. We did our height, weight for our constitutional, and we did 5 others in our mental status, okay? And then we can flip through these quickly. And this just goes into how we did it. And you need one or the other. Again, all of these, you either need a history or physical. You don't need both unless it's a new patient. Okay? So very important to keep that in mind. Okay? And we can just, I think we can just skip through this. I think we've more or less said this. Well, what we're doing is, okay, we'll go over this one. If you notice now in treatment, you know, we made a couple suggestions. You know, we changed the dose early in the morning to help them get ready in school, and we talked about possibly having to increase the doses. Okay, so this meets your documentation. However, clinically, you may want more stuff in your notes. Okay, you may want to have commented about, does the kid have tics? Did you observe any tics? Is he eating? Does he ever have drug holidays? How's he doing with his peers? So these are things you probably do, not necessarily required for documentation, but you would do it because it's clinically appropriate. Okay, let's move on. Okay, there are several other vignettes in your handout. You can read them or we can talk about them later when we have time. Some of it will be covered in this next section. And now we're going on to what our new psychiatric coding scheme is going to be. Okay? Now, you were wondering why we spent so much time on E&M, and that's because this whole system, click again, is based on the E&M. And it's E&M and learning how to use what we're calling add-on codes. And then we're also going to learn about this new concept called interactive complexity. And we're going to learn how to code the E&M plus the psychotherapy plus your interactive complexity. Okay? So we're back to how do we get into this mess? Well, we went through that earlier. Click again. In terms of why all this came about, it was the mandatory review. Rec Research Committee said these codes are, you know, inappropriate and violate scope of practice laws. In the combined codes, we need them split, and then we went back to also having to redo all the psychotherapy. So we can flip back. Okay, so why E&M? Because the whole system is based on E&M as being your primary code and psychotherapy being your add-on, because this was the best way we could separate without the non-medical people commenting that they do everything we do. Okay? So, what's out? Again, all our diagnosis codes, all the individual psychotherapy codes, all the interactive codes, and yeah, everything is there, and keep going, clipping down. And our interactive psychotherapy codes, okay? That's all out. And interactive group, because that's also interactive. And there we go. 90862 is out. You're wondering why I'm applauding, because as you'll see when we show you the breakdown of the dollars and cents, you will make more money using the E&Ms. Now what stays is your psychoanalysis code, family therapy codes, group therapy. Okay? So now you have this crosswalk summary guide, which some of you were looking at earlier, which again just reviews what we just had. So this is something you can look at to try to understand, you know, where we were and where we're going. Okay? So let's begin with our new diagnostic codes. We have two codes now. 90791 is a diagnostic evaluation. It can be used by anybody. We can use it if we want to. 90792 is a diagnostic evaluation with medical services. That was the caveat we put in there to try to differentiate what a medically trained person does versus somebody without medical training. Next. So the difference. Okay, if we just look at the difference, the definition as will be in your CPT manual. It's a psychiatric diagnostic evaluation, which is an integrated biopsychosocial assessment, including history, mental status, and recommendations. Okay? The evaluation may include communication with family or other sources and review and ordering of diagnostic tests. Okay? That's basically psychological testing is what that refers to. Now, the difference? We do other physical examination elements as indicated in recommendations. So in other words, you don't have to do it, only if it's indicated. So the process of your evaluation, you want to start a medication and you feel like you need to check the pulse and blood pressure, you can do that. Or you feel like you need to order more laboratory tests or a cardiogram or anything you feel is medically necessary, you can do that. And that's what separates out part of the codes. And it also includes the communication with others and the prescription of medications, review and ordering of laboratory and other diagnostic studies. So in other words, we can order psych testing as well. And one question.
If you do the evaluation, which
Yeah.
is a medical evaluation, but at the end you decide not to prescribe medication, can you still use that code?
Sure.
Okay.
You just say, medication not indicated.
Okay.
Yeah, you give them reason. I mean, it's a medical decision. You decided. Medicine's not, you're the only one who can decide that. A non-physician can't decide that.
Right.
And one question and we can move on.
Can you just address again the issue of the multiple 90792s and
Yeah.
dealing with insurance
This code was
companies?
specifically written that it can be used multiple times during the context of the same evaluation. So in other words, you would have to say, session 1, interviewed with the parents and document the complete history. Session 2, interview with the patient, child, in our cases, document that. In session 3, interpretation to the parent or family or whatever. As long as you document that it's a part of the same ongoing evaluation, and we felt this was really important to get in. Now, whether the third party will buy it or not, we'll see. But we at least have something in record saying this can be used. You can't tell us we can't do it.
Is there a mandated time frame for that?
No, this is an untimed. I think that the typical time on it was sort of 60, but it's an untimed. Okay. Now, if we look at what are these medical services and activities. Okay, it's the other aspects of your physical exam: height, weight, pulse, blood pressure, etc. Prescribing the medicines, reviewing, ordering any other laboratory studies and tests. What's medical thinking, and this is the most important, consideration in your history of any other comorbidities, both psychiatric and medical, and considering what medications are prescribed by others and their contribution, like blood pressure medicines cause depression. Is this the cause of the depression? Something like that. And what other further medical workup's going to require. And what other medical treatments, yeah. I'm trying not to do a lot of questions because we're not going to get through. Okay, one.
So that consideration of whether a patient should be on medication or not counts.
Absolutely.
You don't need to write a prescription.
That's correct. But you just say, medication not needed, patient, would recommend medicine, but patient refuses medication. It could be anything. It just says that you thought about it. It's part of what your thinking process was, and this was your decision based on that thought process. Next. Okay. And it's integrating everything. Again, this is what we all do. Okay? And so, what code can you choose? Well, our hope initially was we could focus in on the psychiatric code 90792, partly because our documentation is a little less arduous on it. And you use it because you're a physician and you evaluate patients for both the psychiatric and potential medical problems. Now, other codes you can use would be your 2 outpatient codes, 9920405. Those are your higher level 905 being your most complex, and those are your inpatient codes for those of you who do inpatient work. Again, the 99223 is your most complex one. You're probably going to be in either a 205 or 223 level for most of your patients. Go. Next. So, why would we do 90792? Because it can be used when someone other than the patient is there. Now, if you look at your E&M codes, the patient has to be there for at least some of the visit. Okay? And, you know, for those of you who either in geriatric, where the patient basically would be disruptive, or, you know, kids where, you know, either the parent doesn't want to talk in front of the kid, or the kid would be very disruptive and you couldn't get a history, you know, it's nice to have a code where they don't have to be there so you can get what you need to get out of it. Okay. And again, it can be used more than one time, and we specifically wrote that into the code to accommodate ourselves. And it can be used on different days, too. So that it can be an ongoing evaluation. We didn't even put a time unit that it has to be done within 30 days. We just said it can be used as often as you need to until you said the evaluation is complete, I'm ready to go to treatment. Okay. Now, let's look at the dollars and cents of this. Okay? So, a 90791 was valued, was what CMS accepted. It's lower than we actually valued it. They accepted an RVU of 2.80, and that translates into $69.08 on the new Medicare conversion factor. 90792 was valued a little higher, so you get a little bit more. And this is just the work RVU. It's not including your malpractice or your physician expense. CMS was not very nice to psychiatry on that. 90792, they gave a very low practice expense. We think it's because they misunderstood the code and thought it was going to be added on to an E&M, and we would capture the E&M. But it's all being protested now. There's all kinds of letters being written, so I don't know the outcome of this, but right now the outcome is very disturbing. And then the conversion factor, you can see it's a 26.5% drop. After the first of the year, it's down to $24 and change, unless we get the doctor fix. Now, if we just look again, I'm looking at just the work. It's the only way I can really compare it. You can see a 99205 has a work value of 317. And, you know, your 99223, a work value of 386. So you can see it's a lot more. And that was, again, I converted that into what you'll get paid with the 2013 factor. So you can see, you make more money learning to use the E&M on these things. Okay, go. Okay, go. We said that. Okay, there. Now, let's look at pharmacological management. Okay. We did some cookies. There we go. Okay. And okay, I medicate first and ask questions later. Okay. So now 90862. Whoops. You went to. Oh no, you went to the right spot. 90862 is deleted, and we're going to go to our E&Ms now. If you're one who just did straight 90862s, 90862s. This is your bread and butter codes are going to be your E&Ms. Probably 99213, 99214 will be the bulk of your codes. Okay. And this is why we spent the time, because I'm sure a lot of you, that's what you're doing. A lot of med management, unfortunately. So why did we get rid of it? Because it was kind of a generalized, you know, one-size-fits-all codes. Whether you're doing, you know, a stable patient on one medication, comes in every 3 months or so, or your complex, psychotic, bipolar patient on multiple medications who you need to see maybe weekly to get them stabilized. One code doesn't really cover it. So that's why we went to this more expanded system, because it gives you more options to code what you really do. So let's look at the dollars and cents of this. So 90862. Now these I did include your practice expense and malpractice because I used the 2012 since there won't be a 2013 for 90862. And what you can see, to keep clicking, because we'll get the series of the 99 codes. Okay, so we included malpractice and practice expense on both of them. And if you look at 99213, 99214, what you'll see is, well, first of all, look at the RVU on 90862. It's 1.7. Okay, it's not even at the level of a low E&M code. 99213 is a low-level code. Okay, we didn't even get credit for that. You know, we're writing prescriptions, but we're not getting credit for it. Okay, the difference between a 99213 and 99214 is significant in terms of what meets our needs. And just look at the dollars. So you got 57 and change for the 90862 as this year. You would have gotten $68 and change if you just use the 99213. And if your patients are meeting the 99214, you're going to get $102. So it's a big difference for doing it. So that's why we did it. Now all of these, of course, will be cut down on the new conversion factor, but they'll all be cut down relatively because everybody's going to take the cut on this. Okay? So remember, when a psychiatrist says it's not considered psychobabble. Okay, now we're still trying to fight with CMS in terms of what is psychotherapy and, you know, who does it. Might be a never-ending argument. So let's begin. So what is psychotherapy? Okay, we have 3 standalone codes. And this is pure psychotherapy. Nothing else goes on in this code except pure psychotherapy service. And then we have our psychotherapy add-on codes. And they're designated in the CPT book with these plus signs. So it tells you it has to be added on. You cannot code this code alone. You have to code it with an E&M code. And that describes a psychotherapy service which is added on to whatever level E&M you're doing. Okay? So an add-on code is basically a separate identifiable service or procedure that is done in addition to your primary service, which would be your E&M, the way the schema was set up. Okay? And as we said, it's identified in the CPT manual with the plus sign, but you don't put the plus sign on when you bill it. You just bill the code number. The plus only is for CPT identification purposes, so you know when you look it up, it's an add-on. Okay? Let's go. Okay, so what's psychotherapy? This is a CPT definition of psychotherapy. A treatment of mental illness and behavioral disturbance, because some highlights will come up, and which the physician or other qualified healthcare professional through definitive therapeutic communication, and this is what's supposed to be part of the separation between, is it just counseling and guidance, or is there something about what we're trained to do as psychiatrists and or mental health providers that makes our way of talking to patients a little different? So they came up with this definitive therapeutic communication. And with the point being to alleviate emotional disturbances, reverse or change maladaptive patterns of behavior, and encourage personality growth and development. Okay? Now, this again was for the other people who kept telling us they did everything we did. They say we put in this psychotherapy services include ongoing assessment and adjustment of psychotherapeutic interventions, and may involve involvement of family members or others in the treatment process. And that's something a little new we added because, particularly working with children or geriatrics, you often are incorporating someone other than the patient during that session. Okay. Now, we're going back to our time rule. Okay. Now, these are exact time codes. Okay? Which means in CPT time, once you have crossed the midpoint of that code, so for the 30-minute code, once you have delivered 16 minutes, you've qualified for the code. Okay? So 30 minutes is 16 in CPT world. And the series of codes, 45, you deliver it when you've reached 38 minutes, and 60 minutes you've delivered it when you've reached 53 minutes. Okay? So that's CPT time. Now, if we look at our standalones,
we're supposed to have clocks in our offices.
Pardon?
We're supposed to have clocks in our offices.
Well,
Like the chess game thing.
no, like the lawyers. I mean, the lawyers do. I mean, you know, you pick up the phone and their clock's ticking, you know. You know, most of this is going to be our best estimates, and your appointment book will be your guide. If you know, doing 30-minute appointments, you know, for your patient, you know, you do your code and you just make sure you save at least 16 minutes for psychotherapy, your psychotherapy component. You know, if you're doing 45-minute sessions, again, you know, your level of E&M might be a little lower because you're focusing more on the psychotherapy, but as long as you're doing at least, you know, 38 minutes, then you're going to be into that range, okay? And now, the standalones are by the non-medical providers. There's standalones you do not code with E&M, okay? Only our add-ons coding E&M. And you have to make a decision whether you never have your medical thinking cap on, so you would use a standalone because you're doing nothing medical, or whether you're doing fairly low-level medical all the time and would want to code it with that. And that will become a personal decision. There's no right or wrong way. You ask yourself, you know, how you approach these patients, okay? A standalone just describes the service, no medical component. Okay, said that. On to the next. Okay, combined service. Now, CPT and the RUC both recognize that these are really integrated, interweaving services. There's no exact way we can say, okay, now we're doing E&M, and now we're doing psychotherapy. And this was one of the problems in the old codes. You know, it was psychotherapy and then E&M. And it's impossible to differentiate because most of us, you know, it's interdigitated. Sometimes something pops up in a psychotherapy session and our medical light goes on. And sometimes you're doing the medical and all of a sudden you say, aha, there's something going on here in the dynamics, family dynamics, or interpersonal relations or whatever. I need to focus on that in therapy. So you're always going back and forth. So basically, what they're saying is, we know that's how you think. We had to write it in a way that said you're doing something different than the non-medical people. So therefore, this is how we're trying to describe it. So we basically are going to estimate where your psychotherapy component is versus when you've met your criteria for your medical E&M code that you've selected. So go on. Now, how do you do this? Okay, the first thing you're going to do is you're going to choose your E&M code that best describes your service, and you're probably going to go on your components and medical complexity. Now, like we talked about earlier, as a patient comes in, you have a sense of how complex this patient is before you start. And what you do is say, okay, I know I'm going to be at this level of complexity. What do I have to do so I can get credit for this level of complexity? And then you choose the add-on to fit the psychotherapy time frame that you're using. Okay? Okay? Is that how you all feel? I've dropped the bomb on you? So back again to our key components of history, exam, medical decision-making. Don't use time if you're doing psychotherapy. Okay?
How do you show it on the bill? 2 to 2.
Okay, I'll show you in a minute. Okay? So, okay, we've talked about all that. And it's estimate. Okay? So the difference is psychotherapy is non-medical and must be at least 16 minutes. E&M is medical and includes the medication monitoring, prescribing, your testing, your examination. It says other than mental status, but it actually, I think, the examination includes the mental status, and you're writing orders because you're doing your mental status. You know, you're talking to the patient, but out of that is coming your mental status, which doesn't take very long in terms of your total time. And your thinking. More importantly, it's your medical thinking based on your history and comorbidities. Now, a lot of times you're only doing history. You're not doing exams, so the mental status, you know, is moot at that point. And okay, flip the slide. We'll take your question.
Is that the question?
Yeah, okay.
Okay.
So
suppose you're seeing a patient who is overweight and is trying to get a hold of her weight problem. You're having many discussions about medical issues, things that have happened, hip surgery, things that are consequences, whatever, all of that. How does that come into play?
Well, again.
No medication.
No, but okay. So you're going over her complex medical history and stuff, and you're looking, if she's overweight, you're looking at all of the metabolic. So that's your
Health
medical.
problems, yeah.
Yeah, okay, then are you working with her on strategies?
Absolutely.
Yeah, that becomes psychotherapy.
I know.
Yeah, so what you do is figure out what level, it's a complex history there you're doing. So, you're probably at a 99213, even though you're not prescribing medicine, you can do it just, well, what you have to look at, you got your complexity, your risk factors, with all of her medical problems and your complex history. So you're there, even though you don't write a script. And you just say, the other thing is you just say, medication not necessary, working on behavioral strategies. Okay, let's go on, okay. Okay, so now here we go for the documentation, key components, or history, or your exam. So you would choose, which one you want to do. And your medical decision making, always the key. And then you put the time spent on psychotherapy. So a lot of these, you said 20 minutes discuss, 20 minutes going over behavioral modifications or behavioral strategies or anger management or whatever it is you're working on in psychotherapy. And you guesstimate it the best you can. And the most in psychotherapy, who was there? Was it the patient or was it the patient and someone else? And whatever issues you addressed. Okay?
Will they pay for a therapy add-on if they have an outside therapist?
Pardon?
Will they pay for a therapy add-on if they have another outside therapist?
If you're doing therapy. I mean, again, that becomes payer policy, not what you're doing. If you're doing it, code it. They may say, well, no, they have a therapist. You don't need to do therapy. And then you have to go back to them and say, but I am doing therapy because this is how I see my patients, and I am doing it as well. There's no rules that say you can't do it. That's a payer policy rule. Okay. One question, we'll do interactive. Okay. One question. Okay? Is it short?
Yeah, let's say a quick example. You see a chronically depressed patient every week for what we would call individual psychotherapy plus medication management. You see him for 55 minutes for what we would call therapy, and then they're also on medication.
Right.
So you do the E&M code for complexity, but then do you build the highest for the 53 plus minutes for psychotherapy, or do you have to
well,
you
have to back it down, in that case you would do the 45 code. If you see them for 50, if you go 55 minutes and you can do it, minimum E&M in 2 minutes, which you might be able to do if it's not a lot.
Okay, but they kind of have to add up the time.
Exactly, it has to make sense. So, anyway, now let's look at interactive, because we deleted them. Why? And we're going to use this new thing called interactive complexity. And we add this on also to a psychotherapy visit. So you can be doing psychotherapy, but you also may have this interactive complexity component, which you can also add in. And yes, you can do 2 add-ons, and in this case, it was designed that it was known there would be a second add-on.
You define interactive.
We're going to get that, okay? So what is this? Okay, the old interactive codes were meant just to capture your language developmental problems in dealing with children. They didn't like the idea of, we called it play therapy. That, why am I paying for you to play with the kid? So they didn't get it. So we came up with, somebody came up, I think CMS came up with this, Psychiatry didn't. It was meant to capture the difficulties, the increased skill required, the increased knowledge, and some of the increased difficulties in working with children. Because we're working with, a variety of age groups, there's a variety of techniques a child psychiatrist has to be using and be aware of based on the developmental age. It was also used to cover things like needing physical age for other people who can't communicate verbally, like they need a sign board, somebody who can't talk, but they're pointing to you, and you're using that. You need a sign language interpreter for you. It can't be used, click again. It can't be used just for an interpreter who you don't understand their language. CMS considers that discrimination. So they say that cannot be the sole reason why you would use the code. You'd have to come up with some other reason why you would add it, not just that you need a translator for them. So again, this is all what we've talked about. It's an add-on. It's designated with the plus in CPT manual. You always report it with something else. And it describes 4 types of the communication factors we're after now. And these have to complicate delivering the primary procedure. Okay, it has to make that base procedure, psychotherapy's procedure, harder to do. It has to make it require more technical skill, more technical knowledge. It requires difficult management in terms of, you have difficult parents, where you're seeing a lot of interference in your ability to treat the child because of what the parents are doing, and common in child work, but maybe in adult work. Okay, flip side. Ted, you had a question?
No, 5 minutes.
Oh, 5 minutes. Oh, okay. Okay, so what are these communication factors? Well, the little cartoon kind of tells you what can go on in a session. We call it maladaptive communication among visit participants. You're getting interference from the caregiver's emotions or behaviors. Disclosure of sentinel events. The child tells you that they're being abused. And language barriers, but it's looking much more at things like sign language or inability to talk and communicate, like we have in kids where they don't have, not acquired adult verbal language and abstract thinking to make straight verbal therapy a good vehicle for them. So again, it complicates it, and it has to occur during the session. You see a kid, and then the father calls up, the parents are divorced, and you go over the treatment plan with the mom, and everything's fine, she gets it. The father comes up and calls you up a day later and rails you, what are you doing to my kid, and this and that. It's very clear that the issue is between mom and dad, but that doesn't count because it didn't happen during the session. It has to be there during the session. Okay. And again,
the week after or something like that, that doesn't factor in.
No. I mean, I would go in your within 7 days in your pre-post time, but otherwise, there's not good ways to really get a hold of that time. And again, like we said before, it can't be used just for the purpose of translation because it's a violation of federal statute according to CMS. Next. Okay. So these can be reported, interactive complexity can be reported with a diagnostic eval or psychotherapy, not with E&M. You can't report this with E&M. You can only report it with the psychotherapy codes or your diagnostic codes, and it could be either group. It also can be reported with group therapy. This is what happened in interactive group therapy. We do group therapy, and if it's an interactive group with kids or whatever, you would add on the interactive complexity to get that. So now, let's look at our typical patient who would qualify for this. So others legally responsible for the patient care, kids, or adults who have guardians. Others involved in the patient's care during the visit. So it could be a spouse who wants to be helpful but proves they're not. Or if you have to have a interpreter sign language, but because of the way they're doing it or the interpreter's way of trying to explain it or not getting it makes it much harder, you would have to document that the interpreter was having trouble describing the words or getting the history to say that it really complicated it. If you have other third party like welfare agencies, parole, probation officers, school people who would come to the visit as well. Okay, so you report it when just one of those factors is present. Okay, you don't need all four, you just need one. So for child psychiatrists, the fact that you're probably using some form of interactive play techniques, you got it for that. And or if you talk to the parent and everything's fine, that doesn't count as maladaptive. You talk to the parent and they keep asking you repeatedly, but are you sure this medicine won't harm my child? How do I know this medicine? Well, my neighbor told me that this medicine's going to cause all these problems in my child. How do I know it's safe for my child? Over and over questioning you, that's getting into maladaptive. Or, says, I read on the internet that you're poisoning my child, and I don't think it's right that you prescribe these medications for my kid, and starts having an argument with you over the treatment plan. That's going to qualify as your maladaptive communications or interfering behaviors. And you'll see, I'll give you more examples if we can get to some of the vignettes. Okay, so let's flip through, because we've really covered most of this. Okay? So let's look at a vignette now for maladaptive communication. Okay, it's the communication that causes the high anxiety, high reactivity, repeated questions, or disagreements. that complicates the delivery of care. So let's take this vignette. Now this one we're just doing on 90834, straight psychotherapy, 45 minutes. Older child accompanied by divorced parents because the child's not doing well in school, having temper outbursts, and resisting bedtime. Okay? So during the interview, you notice that the parents are really anxious. They're repeatedly asking questions about the process, but more importantly is they challenge each other and blame each other for the child's problems. So you're trying to address the child's problems, but at the same time, you're trying to get them to stop the blame game and let's focus on what we can do to work together to help this child. So it's not really family therapy because you're really focusing right on the context of the child for that visit with the psychotherapy. You know, there's a gray area between would you code psychotherapy or would you code family therapy. So it's kind of like where the focus is of the session. It was you're trying to do individual psychotherapy with the kid, but then the parent comes in and then starts this. That's how you have to try to differentiate this. Maybe easier for you to say it's a family therapy session. I'm going to code family therapy. And
if you do code family therapy, can you add an interactive complexity, or is that
no.
only for the?
It's only for these codes. Interactive complexity does not apply to family therapy. If you do family therapy, it's unclear whether you can do anything for your medical component. There may be a way around it. We're not sure it's going to fly, and I'll try to go into it at the end. Okay? So let's go on. Okay. Now, here's an adult example, middle-aged adult, accompanied by spouse, depression, and the spouse wanted to attend supposedly to help the patient, to do what they could do to help the patient get better. And every time you make a suggestion, the spouse interrupts and starts blaming the patient for not trying. So again, you're dealing with the communication, aberrant communications between the spouse, which in fact may be worsening the problem, not helping it. So that's to apply it to an adult. Now, if the caregiver's emotions interfere, this is the kind of thing you might see. The mother has difficulty refocusing and keeps verbalizing her own job stress of why she can't follow through. And no matter what you're trying to do to get her to focus on what she needs to do to help her kid, it goes back to what her issues are. So that's interfering with your ability to provide the treatment service to your patient. Okay? And I think this is another similar one with just an adult. And this is a geriatric case where the child brings in the parent who's becoming, I guess, more and more demented and not doing well, losing skills. And so the child starts, the adult child is becoming tearful and upset as they realize the fate of their parent. So you're spending time not going over what you need to go over and help the patient, identify patient, but calming the parent, the child, whose needs are very great at the time. Okay. Sentinel event, that's pretty clear. The child, reports somebody's abusing them. During the session, you have no choice. That automatically you have to stop, report it. Okay, next. Okay, we're back to this language barriers. For the most part, it's the use of play equipment, physical devices, for people who have not developed or lost expressive receptive language skills. So it could be a stroke patient as well who no longer has their full ability to communicate well. This one, they used, the example here is group therapy, and you have somebody in there who requires a sign language interpreter. So that's going to complicate the process of the group. Okay, in this case, it does complicate it. It's not just having to provide for that patient, but it's complicating the rest of the flow of the group process. Okay, let's go on. Let's try to get through some of this.
Can you finish in 5 minutes?
Yeah, we'll go through a couple of...
Yeah, you have to stop in 5 minutes.
Okay, okay.
And I think it can maybe be available for questions.
Yeah, we can go through a few of the vignettes. So let's, we'll do one of these and then we'll probably be able to stop. Okay, so when you coding with this, it has to, you have to first code psychotherapy. If you're doing an E&M, you would pick your E&M, then you would pick your psychotherapy level, and then you would add on if you had the presence of interactive complexity. Now remember, this doesn't add time to your code. It complicates the code. So this isn't extending the time per se. This is making delivery of that service more difficult, more complicated, requires more skill on the part of the therapist to do this component. Okay? And it has to occur during the visit. Not the phone calls afterwards or before, but during the visit. Okay? So these are examples that wouldn't qualify. Multiple patients in the visit, but everybody's calm, everybody says, yeah, we agree, we're supporting, we're doing all these things are great. Multiple people, but it's not really complicating it. It's going smoothly. Patient attends the visit, and there's, no sentinel event, no language barriers. It's a normal psychotherapy visit. You wouldn't use interactive complexity. Or, you see the child, and then the mother comes in, or parent comes in for the last few minutes, you explain, what you covered, what the treatment plan is, what you would like her to do for the week, and she says, fine, it's going great, see you next week. That's not really complicating it, okay?
Could you say how you write it on the bill? Because you said don't put a plus.
Yeah.
How do you exactly write it on the bill?
You would write your E&M code first.
Right.
Then you would put down your psychotherapy code.
It's like two lines, two separate codes.
And then you put down your interactive complexity if present.
Okay, but 3 separate codes for the
3 separate codes. You don't need the plus signs when you write the bill.
2 separate, today's date, whatever.
Yeah,
today's
date,
whatever.
Yeah, E&M, psychotherapy, and then interactive if you
So 3
have
separate
that.
charges.
Do you have to list the separate charge for each service?
I think that'll be payer policy.
What does Medicare want?
We don't know.
So
Yeah, you have to. You would probably. Yeah, they valued them. So yeah, because they've been valued, you would probably have to come up with a charge for each of those. So you kind of figure out, okay, it's a 45-minute session. What do I normally charge? How do I want to break it down?
So do we always have an EM code and a psycho? If we spend a half hour talking to the patients about what's going on with their stressors and understanding everything and managing their medication, do we have an EM code as well as a psychotherapy code?
It depends how you want to divide that. It depends. You could say it's all E&M and guidance and counseling, and just code your E&M at the for a half an hour visit, which would be 99214 for most places.
What do you suggest we do in January to submit a Medicare claim for a patient?
Medicare has gone to the system, so you have to use the system.
You have to use.
Medicare has gone to it.
E&M and.
Yeah.
How do you bill it?
Do you put on the same line, or do you?
I would put on 2 different lines. Yeah. So yeah, I think that's clearer probably for what you're doing.
Very detailed. Do you, under your procedure code, do you put it with an EM code and the other one underneath it, or are they side by side? Well, you're going to have a 1500 form for Medicare.
Yeah, I would probably list it side. I think you list each visit. I think that's how they, for each procedure.
I really appreciate her covering volumes of material. She's done an incredible job. And I really want to thank Nancy Nagley, President of New Jersey Council of Child and Psychiatry, for working with New Jersey Psychiatric to bring you this workshop. And if you're busy, you're not alone at the end of this. And we are in the process of organizing more workshops, and we're going to try to do it at chapter level, so you don't have to drive 100 miles to attend these. So we're working on that, and we're also going to see if I can get this video done. And Dr. Seabrook has been gracious enough to allow us to disseminate this information. If we can put it in a format where I can send it to you, we'll do that link to you so you can watch that, and if you have missed things. And the New Jersey Psychiatric Association, I think you are also actively working with the insurance company as we talk to get them to implement these new codes in a prompt manner. So I think Dr. Seabrook will be available for questions after me. And again, thank you very much.
A lot of this, if you go to the ACAP website, acap.org, and go into, I think it's under practice management resources, something like that. And click on that, they have a whole section CPT, and you can get the webinars that ACAS has presented. And those focus on a lot of the E&M stuff. Again, some of the slides will look very familiar. You'll see Dr. Ben Shane did those webinars.